Good evening, everyone. Today, we are going to discuss total parental nutrition in neonates and children. It is an important topic for all intensivists and for all pediatricians, as parental nutrition is one of the important component of the management of the children in ICU. So this will be the outline of today's discussion. The definitions of parental enteronutrition, why TPN is required, indications and timing, what are the constituents of TPN and what are the recommendations, prescription writing and preparation, administration and route of administration, titration and when to stop, monitoring for complications and the complications of TPN. So when it's come to definition, parental nutrition is providing nutrient directly into the systemic circulation. So it bypasses the GI tract and also bypasses the liver. So there will be no first pass metabolism here, you can say, for nutrients. So when enteral nutrition is nutrition in the form of liquid, it is either given orally or by other access, either NG, nasogastric, nasojejunal, gastrostomy or jejunostomy feeding. Earlier, it was oral was not the part of the enteral nutrition. Now it is being added. So any liquid diet given either orally or other access can be considered as enteral nutrition. So what is different between enteral and parenteral nutrition? In enteral nutrition, the nutrients gets absorbed from the small intestine. They through the portal venous system, they enter liver. From there, after the xenometabolism, they enter into the systemic circulation. So when it's come to the parental nutrition, it is directly injected into the central nervous venous system, and it also bypasses the intestine as well as liver. So central nervous system has complications or risk like that introduction of infections and introduction of toxin directly into the venous system, because it bypasses liver, where it certain infections as well as toxins are undergo xenobiotics, metabolic transformation. So whenever possible, use oral or enteral route should be the choice of feeding. The advantages of enteral route is it prevention of mucosal atrophy by luminal supply of substrate, support for the immunity and against pathogens, and support of the intestinal immune system and improvement of the immune competence and prophylaxis against infection and sepsis and improvement of the intestinal perforation. So we know that the TPN is very important, also has some complication risk, but why should we need TPN? So when it's come to TPN is rampantly or extensively utilized in most of the neonatal intensive cares all over the world, and because of the increasing in the preterm births and in the current age. So when it's come to the, let us discuss this graph. This graph shows us the intrauterine growth as well as immediate postnatal growth. Okay, so and horizontal line we have postmenstrual age in weeks, and in vertical line we have weight gain in gram per kg per day. So let us look at the weight. So weight gain is doubling in the last trimester, last 8 weeks. Weight gain is doubled, and it is following the same trajectory even after the postnatal period. When it's come to the and with the most of the micronutrients as well as electrolytes transferred from mother's womb, from the womb into the fetus in the last trimester. When these children are born preterm, sorry. when these children are born preterm or prematurely, they lost the benefits of protective effect of the intrauterine environment and also transfer of micronutrients and trace elements in the third trimester. So these children are at high risk of malnutrition, and important is malnutrition in this age, the immediate postnatal age, is associated with poor neurodevelopmental outcomes and associated with chronic diseases later in the childhood. So when the children are born preterm, they have limited nutrient reserves, immature metabolic pathways, and increased nutrient demands. All this will put them at risk of malnutrition, which leads to the extrauterine growth retardation. And extrauterine growth retardation is very common in children who are born preterm, and children with preterm have other risk factors like gut abnormalities and infections and other diseases. So, as we know that extrauterine growth failure is associated with poor neurodevelopmental outcomes and other chronic disorders like insulin resistance and obesity later in the childhood. It is very important to have provide appropriate nutrients and nutrition in the immediate postnatal period. So goals of parental nutrition is to initiate to correct intrauterine growth reduction, as well as to keep the tangential of the extrauterine growth, to prevent subsequent growth failure, and to provide sufficient energy and nitrogen to prevent catabolism and to achieve positive nitrogen balance. When it's come to the guidelines and total parental nutrition, national is so NICE guidelines, 2020 guidelines for neonates, and European Society of Parental and Enteral Nutrition 2018 guidelines for neonate and children, as well as North American Society of Pediatric Gastroenterology and American Academy of Pediatric Gastroenterology have guidelines for overall for children and adults as well. In India, we have institute-specific guidelines. We don't have national guidelines. We have guidelines from the protocols from the institutes like PGI AIMS. Let's look at the indications. So, according to the NICE, National Institute of Clinical Excellence, the indications for TPN in neonates is that any premature infant less than 30 weeks of gestation or more than 30 weeks gestation, but unlikely to achieve full enteral fluids by 72 hours. Earlier, this was 1 week or up to 7 days, but however, the recent studies suggest there is no mortality benefit whether you start early or late. However, there is definitely a good growth and neurodevelopmental outcome when you start early. Other infants at high risk for necrotizing enterocolitis, or infants more than 30 weeks with absent or reverse fetal umbilical artery flow, or infants with perinatal asphyxia, necrotizing enterocolitis, and gastrointestinal tract abnormalities. So this is omphalocele, where you can see the umbilical sac and the bowel is present within the sac. It is midline defect. Here you can see the gastrochisis. The umbilicus is intact. Here the bowel is erupted outside the abdominal cavity. These children require prolonged parental nutrition and supportive care. When it's come to the indications in infants and children, bowel dysfunction resulting in inability to tolerate enteral nutrition for at least 1 to 3 days in infants, or 4 to 5 days in infants and children, 7 to 10 days in adults. When there is expected bowel dysfunction, at least for these days, the child should be started at parental nutrition early in the course or hospital course. What are the contraindications? Normal functioning bowel is a contraindication. If any acute metabolic derangement, initially correct it and look for the feeding. TPN should not be used during hemodynamic instability or surgical process because it may be inadvertently utilized for fluid bolus. Fluid and electrolytes and acid-base balance must be corrected. Hypoalemia needs correction. When to start? We know the indications right now. As soon as you identify the eligibility, how urgent it is to start. When it's come to the neonates, NICE recommends that as soon as the detection of eligibility, within 8 hours of the detection of eligibility, the TPN should be started in neonates. When it's come to the infants and children, as given above, according to the indications. Within the 8 hours, this 8 hours also sufficient for the placement of central line as well. However, this 8 hours is based on the expert opinion and has no robust evidence to start as early. This only helps in the early parental nutrition, which has good neurodevelopmental outcomes later in the life. So what are the constituents of TPN? And let us look at what are the recommendations for each constituents. So TPN contains, it also provides the fluid or hydration required. It contains macronutrients, which gives calories, carbohydrate, protein liquid, minerals, and vitamins. So how would you calculate for daily energy requirements for a growing preterm? Okay, we have to calculate energy requirements. This is the methodology to calculate for the energy requirements. On this basis, the NICE and European Society of Parental Nutrition has given calorie requirements for neonates, which is 75 to 120 kilocalories per kg. This is calculated on basis of the resting energy expenditure in neonates is 50 kilocalories per kg. Other activity can be 30% above the resting is 15 kilocalories. Cold stress 10 kilocalories per kg. Synthetic effect of it is 8 kilocalories per kg. Fecal loss is 12 kilocalories per kg. And for growth 25 kilocalories per kg. Overall, it is 120 kilocalories per kg in neonates, and it is same all over for all neonates. No need to calculate on daily basis in case of neonates. So when it's come to the infants and children, we have to calculate the energy requirement in ICU, because overnutrition is also detrimental in case of the intensive care. So the resting energy estimation can be calculated on basis of the Schofield equation. So this is the equation required for the resting energy estimation. For stable patients, we have to give resting energy estimation, plus we have to add the energy estimation for the daily activity as well. These are the guidelines for the macronutrients in case of the neonates. So there are two guidelines from European. One is the NICE from the UK, and other is European Society. The most of the guidelines are similar. So when it's come to the energy, start with low kilocalories like 40 to 60 kilocalories per kg, because it helps in the adaptation or transition of the neonate to the extrauterine environment, and the metabolic pathways are also immature initially. Then gradually progress to reach 75 to 120 kilocalories per kg, and therefore onwards the child should be maintained on 75 to 120 kilocalories per kg. So European Society recommends similarly, they recommend 90 to 120 kilocalories per kg and maintenance. Other they all start with 45 to 55 kilocalories per kg. So when it comes to the glucose, initiate with 6 to 9 gram per kg per day, and gradually increase to 9 to 16 kilogram per kg per day. It is almost similar in also European Society with the different categories like preterm, term, and term units. When it comes to the amino acids, first 4 days initiate 1.5 to 2 gram per kg per day, and then gradually increase to 3 to 4 gram per kg per day. Then maintenance and 3 to 4 gram per kg per day thereafter. is similar in European society as well. When it's come to the term neonates, the protein requirement is lower compared to the preterm. Preterm children require more nitrogen for their growth. When it's come to the term neonates, they require less proteins. So it is in preterm the least recommended is 1.5, least tolerable 1.5, and you can go up to 4 gram per kg per day. Less than 1.5 leads to the negative nitrogen balance, and it is not recommended. When it's come to the term, it is at least 1 gram per kg per day. Similarly, lipid for preterm and term units is 1 to 2 gram per kg per day, and gradually increase to 3 to 4 gram per kg per day. After 4 days, maintain 3 to 4 gram per kg per day. It is similar in European society as well. The same in details we have given here. So the most the carbohydrate source is glucose, and is main source and also contributes to the osmolality and parental nutrition. Up to 12.5% dextrose is well tolerated, and as well and no other osmolality increasing agents are present. Adequate carbohydrates are needed to help prevent lipolysis and transient protein breakdown. Generally, glucose started at 10% for newborn on day 1 of parental and gradually increased to 15%. So it is very important to also whenever you change the dextrose concentration and whenever change the bag of dextrose concentration, always measure the plasma blood glucose and also look for any hyperglycemia or hypoglycemia. Both hypo and hyperglycemia are not good for the nutrition of the child. Hyperglycemia can lead to increased lipogenesis and fat deposition, and it can lead to hepatic steatosis and hypertriglyceridemia, increased CO2 production and minute ventilation, and impaired protein metabolism, risk for infection. Increased blood glucose level and associated with increased infectious and related mortality. And hyperglycemia also associated with macrophage dysfunction in lung. So there are risk for pneumonias. So when it comes to the amino acids, as we already discussed, start at minimum of 1.5 gram per kg per day and advance daily by 0.5 gram or to 1 gram per kg per day, and to maximum 3 gram per kg in term and 3.5 to 4 in case of preterm. Maximum peripheral concentration is 3.5. Complications of excessive amino acids. So it is very important to check the bags every day. It can lead to acidosis, elevated blood urea nitrogen, hyperammonemia, high levels of potential toxic amino acids such as phenylalanine, and cholestasis with prolonged administration. So when it's come to the fat, also start with 1 to 2 gram per kg per day in case of neonates, and in case of infants and children, start again low with 0.25 to 5 gram per kg per day. Most of the available fat solution are 20% soluble emulsion, which provides 2 kilocalories per ml. This is the macronutrient for infants and children. You can see here protein. When it's come to the American Society of Parental Enteral Nutrition, so for children 1 to 10 years, it is around, and more than 10 kg, it is 1 to 2 gram per kg. In children 11 to 17 years, it is 0.8 to 1.5 gram per kg. In neonates, it was, we have seen now, up to 4 gram per kg per day. So when it's come to the calorie energy, it is 75 to 90 kilocalories per kg in children, in infants in early toddler age group. In 7 to 12 years, it is 50 to 75 kilocalories per kg. In more than 12 years, it is 30 to 50 kilocalories per kg. Fluid is same as Haliday-Cigar formula, and carbohydrates when it's come to the according to the calorie requirements. Okay, 40 to 60% of the total caloric intake. So calorie requirement is, as we already seen, should be calculated based on the resting energy expenditure plus additional for growth and any activity. When it's come to the fat, it should be the 30 to 40% of the total calorie. It should never cross 50% of the 60% of the energy. So let's look at the, now we have seen the macronutrients. Now let's look at the minerals. So calcium should be started from day 1 itself. For day 1 to 2, 3 to 4 milligram per kg per day. At day 2 onwards, it is 68 milligram per kg per day. Similarly, many differences there in European society. Phosphate should be started as soon as the TPN is started, because TPN, the proteins or amino acids in the TPN can lead to hypophosphatemia due to increased ATP production for the protein synthesis. So phosphate should be initially started at 1 millimole per kg per day and gradually increased to 2 millimole per kg per day. Similar in European society, iron, no need to give parenteral iron in first 28 days, and according to European society, when there is short-term TPN, no need to give iron supplement. Magnesium should be started as soon as TPN. The dosages are quoted by European society: 0.2 to 0.5 milligram per kg per day. In growing period, 0.5 to 0.7 milligram per kg per day. Other trace elements should be started as soon as dosage recommendations are not given in a nice, but dosage are recommended by European society for the zinc, copper, manganese, molybdenum, and chromium. They are given as multi-mineral solution. Vitamins should be started as the standard requirements from day 1 itself. Electrolytes should be started as per the standard. When it's come to the general standards, it is the for initial 2 days electrolytes are not supplemented. However, European society recommends you can start electrolytes and from day 1 itself in case of extremely low birth as well as very low birth weight infants, after ensuring good urine output. TPN volume is according to the fluid volume. It should not be more than the fluid volume. Exception is you can use up to 150 kilocalories per kg in comes to the neonates. The TPN components, the syringes, tubings, and bags, for all components should be protected from sunlight according to NICE, whereas European Society recommends sunlight protection only for lipid solution. Lipid syringe, tubings, and bags needs some protection from sunlight. It prevents oxidation of the nutrients and complications thereof. So we discussed what are components, what are the recommendations of the electrolytes, macronutrients. Now, how do you prescribe to the how you plan to the patients? So when you are planning for the parental nutrition, require first to write down the nutritional requirements, caloric requirements, and also note down the baseline metabolic parameters and anticipated parental nutrition duration. It helps in the appropriate usage of the accessibility of the central veins and the most appropriate device placement and the complications for therapy. So to follow the recommendations, we need to calculate on the basis of weight. When it's come to the neonates, the birth weight or the best dry weight is the recommended. When it's come to children, again best weight or best dry weight. At the time of you should not take the weight of the critical illness period. So there should be calculations of kilocalories per kg per day and the amino acids and how much volume of the lipid and amino acids are required. We can calculate based on this formula, and after calculations we can prepare the solution. Okay. During the calculation, we should also consider for osmolality. When osmolality is more than 900 milliosmoles per kg, we have to use central line for the administration of the TPN rather than peripheral line. So we calculated now. Now how should we administrate? So how should we the TPN? How should be prepared? So now in market, there are available standardized TPN bags. You can use accordingly according to the weight. But however, these TPN bags are not available in all over the country, in most of the geographic regions, as well as in India as well. So this is a standardized solution. You can use them according to the age and weight, and can gradually increase the strength of the solution as well. However, these are not readily available in most of the regions. So we have to prepare them after the calculations. So we should prepare two solutions. Solution A, amino acid and including IV fluid and dextrose. Solution B contains only lipids and micronutrients. IV fluid should be given separately via the another line, and as well as micronutrients like calcium gluconate. So solution A contains amino acids, glucose, and electrolytes. It can also have some trace elements and also water soluble vitamins if a non-lipid containing regimen is there. So solution B contains the lipid. So the available common lipid solution is intralipid, which is 20%, and other is SMOF. It is soya, MCT, and fish and olive oil. So which is also 20%. We can use beta lipid in fact for fat soluble vitamins, and water soluble vitamins can also be mixed with the solution B. So solution A and B should be prepared in a sterile environment with protective equipment, and preferably under the laminar flow. It should be prepared, and this bag should be protected from the sunlight. Bags, tubings, as well as syringes should be protected from the sunlight by a brown to brownish coverage of the by plastic or paper wrapping. So after preparation, how will administrate the TPN? So either we by the peripheral or central venous access. If in peripheral vein, the tip of the catheter is, so the central venous or peripheral venous access are defined by the presence of tip in the, if tip of the venous axis present in the superior vena cava, inferior vena cava, or right atrium, it will be called a central vein. The value. So whenever the standard solutions are available, it are available mostly in the European countries, not readily available in other geographic regions. And when they are available, you can use them. The volume can be used according to the calculations made. Okay. Or when standard solutions are not available, we have to prepare them at our centers. So preparation B, we prepare into solution A and solution B. Solution A will be contain amino acids and glucose solution. Solution B will be the lipid solution. And so the solution A can be some amino acid and glucose, and also contain trace elements as well as water soluble vitamins. Solution B contains lipid plus lipid fat soluble vitamins. It can also contain water soluble vitamins as well. The most commonly used lipid solutions are intralipid, and SMOF is contains other soya, MCT oil, olive oil, fish oil, which can be utilized in cases of cholestasis secondary to parenteral nutrition, or in case of any other liver diseases. Protein we use intralipid. So after prepare the solution A and B should be prepared in a sterile environment with personal protective equipment, and preferably under the laminar flow. And as soon as the preparation is finished, they should be protected from sunlight with black to brown plastic or paper wrapping. So how do you administer? We administer them either through the peripheral vein or central venous access. We call central venous access when the tip of the catheter is either in the superior inferior vena cava or in the right ventricle. If the tip of the catheter is not in the above 3, then it will be called as peripheral venous access. So peripheral venous access is easily accessible, can be needs very doesn't need any. It is easily available and can start as soon as possible. When it's come to the central venous access, sometimes you need to put them under surgical, and it can be difficult access in sometimes. So whenever there is short duration of parenteral nutrition, we use them peripheral vein, and there is no fluid restriction, also use the peripheral parenteral nutrition. However, it has some limitations. Like you cannot give more than 900 milliosmoles according to the European Society. When it's come to the central venous access, we can use high osmolars. We can also do when restricted for high concentrated TPN, which leads to the reduced volume of the fluids. We can also use high osmolarity and dextrose concentration more than 12.5%. So the TPN set, it is the bag, the syringe, and these are the filters. So European Society recommends usage of filters, 0.2 micron infusion filters, whereas the NICE does not recommend any filters. So once you start the TPN, done slowly while monitoring, and do not account for trophic feeds, do not translate increase in fluid one directly to the TPN. Whenever there is change in bag or dextrose concentration, check for the blood sugars. Also monitor for electrolytes and titrate accordingly, as well as calcium and phosphate. So when to stop TPN? So when infants, especially in neonates, when the enteral feeds are more than 100 to 120 kilograms per kg, or the TPN is less than 25 cc/kg per day, the rate of dextrose admission should be tapered to prevent rebound hypoglycemia. You can use the chemistries for the monitoring, or newborns need slower tapering. Lipids can be stopped abruptly. However, the dextrose should not be stopped abruptly. It should be tapered slowly with monitoring blood glucose. So what monitoring is needed during the children in total parenteral nutrition? Daily input output, weight, dextrose concentration and blood gas, serum electrolytes including phosphorus, calcium, magnesium, and daily blood urea and creatinine elevation, and liver function test at least once a week, and serum triglycerides once a week, or at the time of increase in the lipid components. Now let us look at the frequency of the each component. Electrolytes should be daily still table, then serially as indicated. Glucose daily still stable, then serially as indicated. If child has hyperglycemia, then you have to monitor accordingly. If no hyperglycemia, then you can monitor whenever there is change in dextrose concentration or change in BAG. That will be at least once in a 24 hours. Blood urea, creatine, calcium after the first week, and then initially at the start of the TPN, as well as initially until the stable, then daily, then weekly once. Phosphorus, magnesium daily in the first week, then alternate. So growth should be monitored at least weekly once, including head circumference, weight and length. So it should be plotted on the postnatal growth chart. And also if there is inadequate weight gain, which should be at least 70 to 20 gram per kg per day, weight gain in neonates when the child is on TPN. If there is inadequate weight gain, look for the complications and also increase the caloric requirement. What are the complications associated with TPN? So though TPN provides almost nutrient ideal to the intrauterine, it has so many complications or risk factors associated with. There can be mechanical complications associated with the catheter, like catheter-related sepsis, pneumothorax at the time of introduction of the catheter, dislocation of the catheter, air embolism, venous thrombosis, infiltration and phlebitis, blockage of the TPN infusion, metabolic complications like hypo and hyperglycemia, allergic reaction to amino acid or fat, electrolyte disturbances, thrombus and neutrophil dysfunction, hepatic dysfunction, and metabolic acidosis. Infection related is the catheter related sepsis and other infection. Nutrition related can be inadequate feeding, overfeeding, or refeeding. So when we give aggressive parental nutrition from the day one, it can lead to depletion of phosphate or other electrolytes like sodium, potassium, or magnesium, can lead to refeeding syndrome, which manifests as CCF or can manifest as seizures, pneumonia, or muscle weakness or paralysis. So these are the complications related to parenteral nutrition. So whenever there is hepatitis, at least LFT should be performed weekly according to the recommendation we have seen. So once there is hepatic dysfunction, try to reduce the lipid volume or change the lipid component from the intralipid to the smoke, which contains soya, MCT oil, olive and fish oil, which is a balance and which is the anti-inflammatory. So these are the complications. So take home message. So nutritional assessment and calculation of the calories is important. Early identification of the requirement of TPN and aggressive initiation. Correct metabolic derangement if at all anything present. And start slowly and monitor RBS and electrolyte at the initiation and titrate gradually. Maintain calorie and protein appropriately. If you are providing adequate protein but not providing the adequate calories, the proteins will be utilized for the calorie but doesn't lead to the growth. So it's very important to maintain the calorie and protein balance. Central catheter is preferred. It can allow higher concentration, lower volumes, and also good for the prolonged TPN. Monitor for complications while child is on TPN. So this is all. So thank you. You can ask any doubts.
I think Dr. Pandu, again, you have transformed a difficult and a very less spoken topic in a very, very decent and a very easy way. We have a comment, in fact, a compliment by saying thanks, sir. There are no questions as such. If I'll receive some questions, I'm going to share it with you. Thank you for
Okay.
sparing your time, and thank you for teaching us once again. In case I'll receive some questions, I'll get back to you. Thank you
Okay, sir.
everyone for joining. Thank you,
Okay.
Dr. Pandu. Take care.
Okay. Okay, sir.